So, if you begin to put more dials in, you begin to have a better mechanism of control. Again, you pay for more than just the time at the teller's window. We're beginning to see that happen now across the country. CareFirst, this just came out last week. They're paying 12% to primary care practices that deliver NCQA medical homeness. They're paying a management fee. They're paying a coordination fee. They're beginning to pay differently. Your neighbor next door in Minnesota, Medicaid is paying $37.51 on average per member per month for care coordination, for care integration. So you've got another dial, right? You've got a way that you say to the physicians, we're going to pay you this, but only if you coordinate care, only if you integrate care, only if you use technology and have a registry, right? I mean, when I first moved to the Hudson Valley 5 years ago, my cat had a registry. My cat would get notified when it needs its immunizations, right? My wife didn't when she needed a breast exam. I mean, nobody notified us, right? Because there was no system in place to do that. So this $37.51, says to the doc, this is what we're going to pay you for. We're going to pay you for population management. We're going to pay you to take that panel you have to understand what's going on with that panel, And I was great to see Bellin last night. I said, can you show me the sheet where you know exactly, what your panel has and hasn't had? And they could. They brought it out. They know, right? They're beginning to look at data and understand data. So it's really encouraging to me. CMS is rolling out a $10 per member per month. They have 6 to 8 pilots that they're beginning to roll out. So that's, again, $10 per member per month for regular Medicare members in these states where they're going to roll out the advanced pilot. So it's another knob that you turn on. This is the structure of Blue Cross Blue Shield of Massachusetts. This is our alternative pay mechanism. And you can see the light blue line, which is all fee-for-service, and they're moving from fee-for-service to other mechanisms of paying. And increasingly, we're going to have more dials. I want to pay for outcome. I want to pay for wellness. I want to pay for health. I want to demand, value proposition. I don't want to pay any price for rescue care when it could be prevented. I want to put a negative reward system on the hospital communities and on the specialist communities for that. I don't want to pay for that. I want to say, if you have, when you adjust for race, when you adjust for the number of whatever, if you have a rate in your community of a necessity to do stints because you're not addressing these basic issues, we're going to take money away from you. We're not going to pay you more because you do that. I mean, isn't that stupid, right? I mean, we do that now. We pay the system. If they cut off the wrong leg, we pay them to cut off the right one, and we pay them for cutting off the wrong one, right? I mean, we're not giving very good market signals as buyers. So for IBM, we pay 100% for primary care. We now are going to incent our employees next year. We're going to pay them $150 to take their health risk assessment, to sit down with a primary care provider and go over that with them and develop a plan against their health risk assessment, right? Why are we going to do that? Well, partly we think that makes a lot of sense. Do we think this is going to pay? You bet we think this is going to pay. But mainly we're going to do that because we want to incent a doctor-patient relationship, right? Because it's going to have to be with their primary care provider. And little by little, we put the lobster in the cold water, and little by little you just turn up the heat. I mean, right now it's free to see your primary care doc, and increasingly it's going to be more and more money if you decide to go and see that ear, nose, and throat doc for your sore throat, right? I mean, why would I not do that, right? But at the same time, we're educating our employees. We have wellness programs, very robust. We have communication and education. I can show you the little video clip that we send out to our employees about what a medical home is and why you should be looking for one in your community, right? At the same time, we're helping our communities migrate to this by beginning to pay per member per month for this. So in the Hudson Valley, we pay $12 per member per month if we can find a medical home and they're level 3. So this is some of the booklets that we've produced that are available for free out on the PCPCP website. We've got the pilots, where they are, what's going on with them, what's happening. We've got a brochure about medication management. We've got the purchaser's guide, or how you as an employer begin to approach the healthcare plans about buying it. We have a value-based insurance design, or how you begin to look at designing this into your benefit design. I mean, so there's a lot of meaningful information. We have one about HIT and medical home, and then a really good consumer guide, which is really designed for you to make available. Again, it's all free because we want to change the system, right? For you to make available to your employees about this model, along with a lot of video stuff that's out on the PCPC website. Again, this, I've already told you the Danish story. This is the concept of the White House. This comes out of a meeting last October. The patient-centered medical home is the base for this. The president calls it the hub where primary care physicians are empowered to take action. In law, it's called the medical home. Accountable care organizations are the superstructure that allows this to happen. Accountable care, when you begin to look at this across the community, it's the kind of structure from top that allows the money to flow in the right direction, that allows bundle payments, that allows different payments. So the concept of the primary care can bundle up. I mean, you know, a lot of people don't understand that. They think accountable care is really taking a hospital and telling everybody that they're an accountable care organization when they're really an unaccountable care organization. So this is the executive order for the military, the same with the VA. Again, this is the concept of accountable care and PCMH, because you're going to hear that a lot. I want you to be aware of that terminology. PCMH and accountable care, they're the same thing. They're just different views. ACO from the top down, PCMH from the bottom up. PCMH is the kind of care, it's the principles that you want for your mother, right? I mean, it isn't that complicated. The way the money flows in the system that allows that structure to happen, how you create the structure across the community, is the accountable community or the accountable care. Now, if you want to have a view of what this is going to look like, I would say you look at that paper from Geisinger, right? And the reason I would say that is because the people that they hired are now working at CMS to write the rules come from Geisinger. I think that's a good indication of what it might look like. I think this is the law about accountable care. Accountable care is an entity in which there's at least 5,000 primary care, Medicare beneficiaries. It's a legal structure that allows for that structure to occur. This is Section 5702 in the law, if you're interested in reading law or you have trouble sleeping at night. Again, this is the law. This is the ACA. The accountable care organizations are medical homes and independence at home are really key sections. 2702 or 2014 has all the details on accountable care, et cetera, if you want to look at that. This is what it looks like in a community. This is Hudson Valley. We now have about 900 providers at level 3. But this is kind of how a community marches out across the community. And what's encouraging is I see that here in Green Bay. When you guys are really thinking about that, you're really looking at how you create a value-based thing. I think what's really important, and what I would encourage you all to do, now that you're here together in your room and you're talking about this, is to get back together on a regular basis to create sort of a business community. Many communities have that. I can introduce you to Andy Weber, the guy that runs this nationally, the National Business Coalition on Health, where these communities get together on a national level. But I think it's really important that you keep this dialogue between the hospital and the buyers of care, and you begin to give some feedback about what it is you want and begin to have discussions. You look out there. I know that that's not your day job. I mean, most of you guys are busy doing other things. But you need to focus at least a little bit of attention to this because it's going to kill you if you don't. It's just so expensive. This is kind of how the money flows. We're now paying top dollar for rescue care. We really want to move to paying for continued health, to pay for no hospitalization, to pay for efficient and successful outcomes versus paying the other way around. That's all we're doing. It isn't rocket science. We're just paying the wrong money for the wrong thing at the wrong time with the wrong people.